The key in the cranial nerve examination is inspection. Two-thirds of the signs in the cranial nerve examination can be identified on inspection, and hence it is very important to spend time and effort here. We will now demonstrate the cranial nerve examination.
Morning, sir.
Morning.
Dr. Marianne, thank you for letting me examine your face. Could you help me to just remove your mask for me?
Sure.
And then just have a look at you first.
At this stage, immediate things to pay attention to are whether there's any ptosis, whether there's any obvious down and out eyes, whether there's any facial droop. And make note of the patient's speech as you greet the patient. Walking around the patient to look for scars is critical. Do not miss, in particular, the post-auricular scar of a parotid resection, which may have led to a 7th palsy.
Right. Could you help me take out your spectacles?
Sure.
Have a look at your eyes first. I'm going to turn off the light.
Yep.
Okay.
I'll turn the light on for you.
Thank you.
You can ask the examiner to help you with the lights on and off. Examine for anisocoria in the dark and in the light.
Alright. I'm going to go a bit more closer right now. Tell me if it's uncomfortable, okay?
Sure.
Okay.
Some patients are sensitive to light, and if so, approaching from the side rather than from directly spot on helps to reduce discomfort to the patient.
Alright, could you put on your spectacles for me?
Mm-hmm.
I'm just going to check grossly how well you can see. Does my face look intact? Any
Yes.
missing parts?
No.
Okay. Could you cover your right eye with your right hand?
Yep.
Tell me how many fingers you see.
2, 1, 4, 3.
And change that?
1, 4, 3, 2.
Okay, good. Right now I'm going to be seeing the completeness of your visual field. I'll be having this ball come in from the side.
Yep.
Have your eyes focus on my nose at all times. And the moment you can see the red ball in your vision, just tell me that you can see it.
Sure.
Okay? Could you cover your right eye with your right hand again?
Confrontation visual field analysis relies on the red ball being directly equipositioned between yourself and the patient. You're comparing your visual fields with the patient.
Yep, I see it.
Good.
Yep, I see it. Yep. Yep, I see it.
Bring the red ball in from the side. Do not cross the vertical or the horizontal midline. Bring it in gradually until the patient says that he is able to see it. At this point, you should be able to see it as well.
The other side? Okay.
Yep. 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 Yep.
Okay, good. I'm still going to use the red ball. Could you continue to focus on it and tell me whether you see double or single?
Yeah, I see one.
One.
Yep, just one. Yep, one. 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 Yep.
One.
Yep, one. One. Yep, one.
Good. Okay.
When testing for the extraocular movements, stress the extraocular movements by moving to the extremes of the vision. Sir, you mind to look over here? Over to this side, please. Okay. Keep your head still.
Yep.
Just move your eyes. Look over to this side, all the way here. Okay. Do you see one or two?
One.
Okay. Rely not just on the patient's report of diplopia, but on whether visually you observe there's any failure of abduction or adduction in this position. If you notice that there's any ptosis or any non-conforming ophthalmoplegia, this is also the time to check for fatigability. So keep looking at this over here. It's going to be a little bit long. If you're very tired, let me know and I will stop.
Sure.
It would typically be necessary to wait for 20 seconds or so before declaring that there is no fatigability.
Okay, so now I'm going to see how good your facial muscles are working.
Okay.
Could you raise your eyebrows for me?
Mm-hmm.
Okay, then squeeze your eyes shut tight and bury your eyelashes. Good. Okay, relax. And then puff out your cheeks for me. Don't let me push the air out. And give me a big smile. Show me your teeth. That's good. Okay. Right now, to see, look into your mouth. Could you open, please? Say and stick out your tongue and move it left and right for me. Excellent. Okay. I'm going to check the sensation of your face with this cotton bud. Close your eyes and let me know whether the sensation is the same on both sides.
Okay. Yep, the same. Yep, same.
Okay. Then open your eyes.
When examining facial sensation, we typically use a cotton wool rather than a toothpick so as to avoid causing discomfort to the patient when the face is quite sensitive. It is only necessary to test a single sensory modality, as your spinothalamic and your dorsal column tracts travel together in the face, and performing both modalities separately has no additional localization value. Ensure that you have the correct touch points in the face. The first division of the trigeminal nerve is tested just above, in drawing a straight line where the pupil is, just directly above here. Right? So let me know if you can feel this on both sides, left and right.
Yep.
And close your eyes, please. All right. Can you feel this?
Mm-hmm.
Is it the same on both sides?
Yep, the same.
All right. So just a gentle touch will do. You need not stroke or you did not dab. Just a single touch will do. The face is very sensitive. The second division of the trigeminal nerve is tested directly below it over here. Does it feel the same on both sides, sir?
Yes, it does.
The third division is below. Feel this, sir.
It's the same.
You will want to avoid testing too medially, for instance, over the nose, as the first division of the trigeminal nerve has some sensory fibers that come down. Neither do you want to test too laterally, because you may get some cervical dermatomes laterally.
I'm going to push against your jaw.
Yep.
And just keep your mouth open, okay? Alright. And I'm going to see how well you can hear.
Sure. Yep, can hear this.
Good.
Yep, can hear this as well.
Sounds the same on both sides?
The same.
Okay. Remember to use a 512 Hz tuning fork, not the longer 1 to 8 Hz tuning fork for testing hearing. And if there is any suggestion of a hearing defect, you will want to do a Riley and Weber test as well.
Okay, now I'd like to test the strength of your neck.
Mm-hmm.
Could you push against my hands here like this?
Yep.
And the other side. And shrug your shoulders up, don't let me push you down.
Yep.
Good. Right. So could you put your finger to your nose and touch your fingertip to my fingertip?
Sure.
Then go back and forth.
Mm-hmm.
And change hands. Alright. And follow me now. Go up and down. Fast as you can. And change sides.
Yep.
Good. And then could you put your hands up like that? And close your eyes and hold it. Okay, you can relax. Thank you.
The cranial nerve examination is a fluid one. You may have noticed that we did not do the cranial nerves in order from 2 to 12. You may choose to do certain steps first or later, depending on what the stem tells you and depending on whether you identify any abnormalities on inspection. For instance, if the stem of the station is this patient complains of trouble seeing, you will want to do the eye-related examinations first. On the other hand, if the stem is this patient has difficulty swallowing, you probably want to examine the speech, the facial nerve, and the lower cranial nerves first. You will also want to move on from the cranial nerve to examine the cerebellar system and the limbs as is necessary. For instance, if you find that there is bilateral fatigable ptosis, you will want to check for neck flexion, You want to check for shoulder avduction and whether there's any fatigability in the proximal muscles of the upper limb to complete your examination and have a solid diagnosis of myasthenia gravis. The same will apply if you find any other diagnosis in the cranial nerves that may have signs in the upper and the lower limbs. This is a cranial nerve examination.